All right, welcome back. So we're on to part 2 of connective tissue. Turns out this one's going to be a 3-part series, so I apologize for that. It's going to be fairly long, but if it's any consolation, I'll make it up to you when we get to the skin, because that should only be one quasi-short lecture, because the skin chapter is not especially long. So last time we talked about epithelial tissue. Remember that epithelial tissue is the type of tissue that covers and lines. So the two examples I kept returning to over and over again were the skin is a type of epithelial tissue, right? Because it covers all of you. It forms a barrier protecting you from your external environment and keeping things in that we want to keep in, like water. And then the other, so that's your covering. And then the lining types of epithelial tissue, I talked a lot about the small intestine, but you've also got epithelial tissue that lines your respiratory tract, lines the upper part of the gastrointestinal tract. And so remember, those also can form a barrier, but those types of epithelial tissue, in addition to being a barrier against some things, also function to allow for absorption. So for example, we talked about the tissue in the lungs, the alveoli, and how that lets gases, specifically oxygen and carbon dioxide, diffuse one way or the other across that cell, right? So we finished up with epithelial tissue, this time moving on to connective tissue. So whereas epithelial tissue covers and lines, connective tissue, to no one's surprise, connects things. So there are 4 classes of connective tissue that you can see here. So there's connective tissue proper, which is where we're going to spend a lot of our time, and then cartilage, where we're going to spend some of our time in this talk, and then we're actually not going to talk about bone or blood. We cover bone primarily in PEPROF 201, so you may have already heard it, or if you haven't, you'll hear it when you take that class. And then blood, we're actually going to talk about later in this class. Blood has its own chapter, which we'll cover after test 1, so after we get into the skin. But speaking of connective tissue broadly, the functions of connective tissue are, first, binding and supporting. So if we bind something, right, we tie it together. So as an example there, your ligaments, so hopefully you'll remember that ligaments connect bones to bones, and so they bind the bones together, right? And so the ligaments are a type of connective tissue proper. Specifically, they are dense, regular connective tissue, and I'll tell you what that means here in a little bit. So connective tissue can bind things together. There's other types of connective tissue that can bind things together. So areolar tissue we'll talk about as kind of being this universal packaging material that connects epithelial tissue to deeper tissues like the muscular tissue, for example, kind of through some other tissues like fascia. So they can bind multiple tissues together. And then connective tissue also plays a supporting role. So sticking with that areolar tissue, like I said, is underneath most of your epithelial tissue. Specifically, it's underneath your skin. And so from a supporting standpoint, it does provide some physical support for that overlying epithelial tissue, but it also provides support in that it has the blood supply. So the actual capillaries will run through the connective tissue, and then the oxygen from that blood supply will actually float up, if you will, or more scientifically, it'll diffuse through that connective tissue to make it into those epithelial cells. So the areolar connective tissue then not only physically supports that epithelial tissue, but it also supports it in terms of supplying the things that the epithelial tissue needs. So supplies nutrients like amino acids and glucose, oxygen, provides a way for those epithelial tissues to get rid of their wastes, and then also provides sort of a fluid backup or a fluid source for those tissues. So it provides physiological support, provides functional support as well. And then in terms of protecting, so since bone is a type of connective tissue, think back to what we talked about in PEPROF 201 in Structure 1, where we talked about the dorsal body cavities, right? So that includes the cranial cavity and the vertebral cavity. So inside of the brain, or inside of the skull and inside of the vertebral column, or inside of the spine. And so the job of the skull and spine is to protect your central nervous system, to protect your brain and spinal cord. Similarly, your ribs obviously protect your lungs and your heart. So protection is a function of connective tissue. Having said that, one of the classes of connective tissue proper is adipose tissue, is fat. And so one of the functions that fat serves is a protective function as well. It provides sort of a physical padding. So it's most of the fat that we store is underneath our skin. It's called subcutaneous fat. And so it provides a protective role in terms of, like I said, providing some padding. So if we get, hit by some object, it helps absorb some of that shock, so we don't transmit as much of the force, to the bones or to the nervous system, in that case, the peripheral nervous system. Other things that connective tissue does, serves an insulating function, specifically in the case of adipose tissue, so fat. So fat is a really good insulator, and so as I mentioned, most of the fat that we store is subcutaneous, it's under the skin, and so that sort of provides this barrier where the muscles are going to generate quite a bit of the heat that we generate, and so the fat helps keep that in. For better and worse sometimes, right? So in the cold, that's an advantage, and then the more adipose tissue you have, the easier it is to, within limits, to stay warm. And then the flip side of that, of course, is that if you are an athlete with a large amount of adipose tissue exercising in the heat, well, it gets harder for you to disperse that heat, and so then you're more likely to suffer heat illness. So think about somebody like a large offensive lineman, in fall camp for football, where they're out there, run wind sprints and covered in pads when it's 105 outside. Those kinds of things. So the insulation kind of goes both ways. In terms of storing fuel, so as mentioned, adipose tissue, fat tissue, is one of the classes of connective tissue proper, and so fat's a really effective fuel source, and we'll talk more about that when we get to that section on connective tissue proper. And then connective tissue also transports substances. So obviously blood being a huge example there. So the primary job of blood is to transport things. Primarily, blood is going to transport oxygen and carbon dioxide, but in addition to that, it obviously transports, protein, fat, glucose, plays a role in our immune system, transports all kinds of stuff, right? So blood is kind of the highway. It helps things get where they need to go. But in addition to that, as mentioned, the areolar connective tissue, for example, is primarily fluid, and again, it's a type of connective tissue proper, and so it's going to transport things from the blood to the overlying epithelial tissue, as I mentioned earlier. So things will be transported through it. So that's another function of connective tissue. All right, so in terms of the structure of connective tissue, whether we're talking about something like loose areolar tissue, or whether we're talking about something like a tendon or a ligament, they all have the same basic three elements. It's just what concentration or what balance of those elements they have. So the three elements that they're going to have are the ground substance, and then they'll have fibers and cells. And we'll talk about each of these. So you can see on this slide, we're going to get into the ground substance. So what this picture is, it's really a depiction of areolar connective tissue, which, as mentioned, is a type of loose connective tissue. And so areolar tissue, in terms of the concentration of these things, areolar tissue has lots of ground substance, relatively few fibers, and relatively few cells. But it serves as sort of a good mock-up, a good starting point to talk about all the different components of connective tissue, and then we'll talk about how the concentrations change when we change tissue types. So the ground substance, as it says on the slide, is kind of the space between. And space is sort of a misnomer. It is basically the fluid, right? So the ground substance is primarily the fluid. So as you can see in this depiction of areolar tissue, this kind of light blue, all of this stuff that's not something else is extracellular fluid. It's just fluid that everything else is floating around in. So that's the ground substance. So the ground substance is the fluid that things float in. It's kind of a way to conceptualize it. So it's primarily fluid. Also includes adhesion proteins, which I won't ask you about, but adhesion proteins are proteins that help things like our little cells stick to the extracellular matrix, and includes proteoglycans. What are those? So proteoglycan is a combination of protein and glucose, so it's a protein and a sugar, and it's not just one in one, it's multiples, right? And so the most relevant type of proteoglycan is called a glycosaminoglycan, or GAG for short. And so what those are is a protein core that has these long strings of sugars projecting off of them. The example, or the way that the book explains it, is it looks like this protein core, and then all of the carbohydrates or all the sugars kind of come off of it like a bottle brush. So if you've ever seen like a baby bottle brush where there's like this, this midline metal part in the middle and then a bunch of little hairs that come, or brush fibers that come off of it, very similar appearance in terms of molecular appearance of GAGs. Why they matter and why I mention them is that they are charged, and so with them, they're going to attract water molecules, basically. And so when I say charged, they're electrically charged, and so negatively, specifically. And so they are then going to attract a lot of water molecules. So the more GAGs a specific type of connective tissue has, the more water it's going to hang on to. And the more GAGs you've got in there, not only is that tissue going to hang on to more water, but you've got then a higher concentration of these proteins and these carbohydrates and these long strings of those carbohydrates. And so a higher concentration of GAGs makes that extracellular matrix more viscous. It makes it thicker, so more like motor oil and less like water. So where this will come up is we'll talk about different types of cartilage. And so the type of cartilage that lines your long bones, hyaline cartilage, has a really high concentration of GAG. So it's most of the extracellular matrix, or it has a really high water concentration and a relatively low fiber concentration. But the water that it has, because it has so many GAGs, is really, like I said, really thick, really syrupy, rather than being just like tap water, right? It's not as thin as that. So first element then, ground substance, mostly fluid. Second element then are the connective tissue fibers. There are 3 fiber types: collagen fibers, elastic fibers, and reticular fibers. So your collagen fibers, kind of the way to think about those are as essentially the steel cables of connective tissue. So they run between cells, they run between other fibers, and so they kind of tether things together. So there are different types of collagens we'll talk about in a little bit. I don't expect you to know different types of collagen. Like, we're not going to get into all the different types. It'll come up in a little bit because I talk about how they change across the lifespan. But in general, collagen fibers, like I said, are kind of like those steel fibers or steel cables. And so they don't have a lot of give to them. Now, certain types of collagen have more give than other types, but in general, collagen fibers don't have a lot of give to them. So, for example, your tendons and ligaments are primarily collagen fibers. So when you stretch a ligament out, eventually you're going to hit its end point, and then that's just where it stops, right? And so the collagen fibers are the really dense, cable-y fibers that determine that stopping point. That's as opposed to the elastic fibers, and the elastic fibers on here are kind of this orange color. Sometimes they're yellow, but on here they're kind of an orange color. And so elastic fibers, as you would expect, are more elastic. So they're more like a rubber band. So when you pull on them and then release that tension, release that pulling apart force, the elastic fibers snap back to their original length. And so in the case of ligaments actually, compared to tendons, have a higher ratio of elastic fibers to collagen fibers than tendons do. And so ligaments are a little bit more elastic than tendons are. So they snap back to their original length more easily because of the higher concentration of elastic fibers. So if you pull on a tendon, what's ultimately going to stop that movement, or a ligament, what's ultimately going to stop that movement is the collagen fibers, and then what's going to cause that tissue to bounce back to its original shape is the elastic fibers. And then reticular fibers, we're not going to talk about much. On this drawing, they're these little blue things. Because reticular fibers are pretty fine. They sort of form kind of a skeleton, sort of a mesh is a way to think about them. So they help provide sort of a form to that extracellular matrix, and they sort of provide this form scaffolding, if you will, like around blood vessels and those types of things. All right, so again, the 3 main elements of connective tissue, so ground substance and fibers, and then the last one is cells. So now we're talking about cells, just to kind of, so we know where we are. So in terms of connective tissue cells, so depending on which type of connective tissue we're talking about, there will be different types of cells, or primary cells that are in there. So for example, if we're talking about connective tissue proper, so if we're talking about areolar tissue, if we're talking about tendons or ligaments, the primary type of cell that's in there is a fibrocyte, right? So anytime you've got fibrocytes, fibroblasts, you're probably talking about connective tissue proper. So there's two parts to that word then. So there's the first part and then the second part. So the first part tells you what type of tissue we're talking about. So chondro is cartilage, fibro is fiber, right? And so again, you're going to find that generally in connective tissue proper, and that'll make more sense here in a second. And then osteo is bone. So fibro, fiber, chondro is cartilage, and then osteo is bone. And then the second part of the word tells you the age of the cell, so how mature it is or not. A blast cell is an immature cell, so it's young. A cyte is a mature cell, it's all grown up. The reason the age of the cell matters, and it's not necessarily like, I mean, it's kind of tied to chronological age, but it's not strictly tied to that. But the reason that matters is it's determining what that cell is doing. So the blasts, the young immature cells, two important things about them. One is that they're undergoing mitosis, so they are splitting and making copies of themselves. And so those cells can make new ones, right? And that's important for tissue regeneration, because if we don't have any immature cells, if we don't have any cells that can make copies of themselves, when that tissue is damaged, it's harder to fix it, or potentially impossible to fix it. And then in the case of cytes, so with our mature cells, those are going to, well, I left off the second thing, sorry. The other thing that the blasts do, other than the fact that they are mitotic and split, is they produce the extracellular matrix. So in the case of chondroblasts, they're going to lay down the collagen fibers that help form the cartilage. In the case of fibroblasts, they're also going to lay down collagen that help form the tissues and ligaments, the tendons and ligaments. And then in the case of osteoblasts, they're also going to lay down collagen. So all three types lay down collagen, but they're going to lay down the collagen, in the case of osteoblasts, that sort of forms the scaffolding that we're going to embed calcium crystals in, that's going to give bone its characteristic hardness. So the blasts generate the extracellular matrix. So the two things I want you to know about the blasts then, they're mitotic, they split, make copies of themselves. And then the second one is that they create the extracellular matrix. The cytes, the adults, basically don't have time to do all that stuff. They're out of their lower energy, and all they do is maintain the extracellular matrix. So if there's collagen fibers that are there, but they've broken, the chondrocytes can help repair them. They can generate a little bit more collagen to help repair those fibers. So they're involved in repair, but they're not generally involved in the generation of new matrix. They're less adept or less good at that. So in addition to the connective tissue cells, whether we're talking fibroblasts, chondroblasts, osteoblasts, etc., in addition to those, we're also going to have some fat cells, so adipocytes. So here's our little fat cells here. White blood cells that are going to be involved in the tissue repair process, and then mast cells, and our little mast cell is pictured here. Mast cells are interesting cells, so they tend to cluster along blood vessels, so you can see this little capillary here, and our mast cell right next to it. One of the reasons that they're interesting is so they're going to play a role in the body's inflammatory response. So you can see this one kind of looks like it's polka dotted, right? So you see all these little darker green spots. So those are generally referred to as granules, but a way of thinking about them is basically those are vesicles. And so those then have a variety of chemical messengers in them. So if there is damage to this tissue, so let's say if you get a cut that goes through the skin and gets down into that underlying connective tissue, then the mast cells will also be damaged, or potentially just sense through chemical messengers. They'll sense that there is tissue damage nearby, and they'll release kind of this soup of inflammatory chemicals. So among them are heparin, which is a really potent anticoagulant. So they're going to increase bleeding to the area. The other thing that they're going to increase is a messenger called histamine, which is one you've probably heard of before. And so one of the things that histamine does is it makes these capillaries extra leaky. And so the reason we're making these capillaries leaky opening up the spaces between those, the endothelial cells, tying this back into our last talk. The reason that we're making those capillaries leaky is we're trying to allow for white blood cells and macrophages like this guy to make their way into the damaged tissue so they can attack any invading organisms. Because think about it, if we're talking about a cut of the skin, there's probably some bacteria and dirt and some other things that have gotten into that wound that we need to clean up. And so we want to get those white blood cells to the area as fast as possible. And so the mast cells are sort of responsible for sounding the alarm by using those various chemical messengers. Like I said, the two big ones are heparin and histamine, but there are others that we'll talk about in the next talk. And then the last one on here in terms of other types of cells found in connective tissue, those are our macrophages. I mentioned that a second ago, so here's our macrophage. So those are your big eaters. Those are the ones that are going to be responsible for attacking invading bacteria. They can also play a role in, so if you got a cut and then in doing that you damage some of these collagen fibers here, collagen fibers or elastic fibers, then you would need to repair those, and so the macrophages can come through and kind of clean up those frayed collagen ends so that we can rebuild that collagen or lay down new collagen. So they're kind of responsible for cleaning up the area. All right, so in terms of types of connective tissue proper, so this, I was going to say harkens back, I guess that'll work. So this harkens back, recalls the first slide, or second slide, either way. So remember, in terms of classes of connective tissue proper, you've got, or classes of connective tissue, sorry, you've got connective tissue proper, cartilage, bone, and blood. So now what we're going to talk about is connective tissue proper, and it is subdivided into two categories. So you've got loose connective tissue and then dense connective tissue proper. And then loose has three subcategories. So the first type of loose connective tissue proper is called areolar tissue, which is what's pictured for you here. And so again, that was kind of that general mock-up that I was showing you and that the book uses on the past couple slides, where you've got lots of extracellular matrix, and so you can see this ground substance, lots of ground substance, lots of extracellular matrix out here. And then in addition to that, you've got some collagen fibers, these big kind of pink ones. You've got some elastic fibers, these little thinner ones here. And then you can see the fibroblasts. So again, the fibroblasts are going to be cells that are going to generate that extracellular matrix, and importantly for us, they're going to generate collagen. So as mentioned, areolar connective tissue is kind of this, this general packaging material that is found underneath the skin and around most of the organs in the body. So it's going to serve several purposes. As mentioned with respect to epithelial tissue, remember epithelial tissue is avascular, it doesn't have a blood supply, so it has to get its nutrients that it needs from that underlying connective tissue, which is almost always areolar tissue. So areolar tissue is going to have the blood supply, which then means it has the oxygen, it has the amino acids, so the protein building blocks, and then glucose that we're going to need, or that those cells will need. In addition to that, so as you can see, there's lots of ground substance here. So areolar tissue serves as a really important water reservoir. So kind of the two big areas where we store water, if you will, are in the blood plasma, which is the fluid component of the blood. So your red blood cells float around in plasma. So that's one of our major sources of water in the body. And then our other big source of water, or big, like I said, storage reservoir, if you will, is in that areolar tissue. Because again, that's underneath your, all your epithelial tissues, or almost all of your epithelial tissues are going to have areolar tissue underneath them. And so they're going to have, that's going to serve as that sort of water reservoir. In addition to that, the areolar tissue also is dotted with adipose cells. So there are some fat cells in it. I'm trying to make sure I hit all my big points about it. It's also, areolar tissue is also around capillaries, is kind of the one I hadn't gotten to yet, although I mentioned that on the previous slide. So typically kind of deeper in the areolar tissue is our adipose tissue. So you can have adipose tissue, and remember that's fat, anywhere that you have areolar tissue, but so the kind of the layers from superficial to deep in the skin. So you've got your epidermis, your dermis, and then you'll have your areolar connective tissue, and then deep to that you'll have your subcutaneous fat, so your adipose tissue. So then one of the differences with or between adipose and areolar tissue is that adipose tissue has less ground substance. There's not a lot of fluid to it, but there's lots and lots of cells. So now what's pictured is adipose tissue, so it's fat. And so you can see there isn't near as much space between the cells in the adipose tissue. So it is primarily adipocytes, or sometimes people pronounce it adipocytes, either way. But it's primarily fat cells. And so you can see the really obvious prominent fat droplets there. And so, as mentioned, the vast majority of our fat is stored subcutaneously, so under the skin. Now we do have other fat storage sites. One of the ones the book mentions, and is on this slide as well, is around your kidneys and behind your eyes. And then you can also have what's referred to as visceral fat, so that's fat around the organs. And so sometimes if you see somebody that has like a really big beer belly, one of the things that they may have going on is that they may have a pretty significant amount of visceral fat, so fat around the organs. And there is some evidence that that particular kind of a fat distribution is a little less healthy than if they had the same amount of fat that was primarily cutaneous fat, or sorry, subcutaneous fat. So as far as adipose tissue or fat goes, so it serves a number of important purposes. The primary one, though, obviously, is that it acts as a fuel. And so fat is a really efficient fuel source, for better or worse. So the approximation is that for every pound of fat, you have about 3,500 calories in that pound, right? And so if we think of our average college-age male who is, let's say, 12% body fat, and I should have mathed this out before I was doing the talk, but I just grabbed my calculator. So we'll do it as I'm talking. So your average college, actually, that's a pretty lean college-age male. So we're going to say our college-age male is 15% body fat. And so we're going to say that they are 175 pounds. So if they are 175 pounds and they are 15% body fat, then they are a little over 26 pounds of their 175 is fat, right? And so if they've got 26 pounds of fat on them, and then each pound has 3,500 calories, they have about 91,000 calories worth of fat. So that's a pretty significant energy reservoir, is a positive way to look at fat tissue, right? So you've got lots and lots of calories. So one of the old physiology textbooks I used had the example that the amount of carbohydrates you can store, so glycogen is your storage form of carbohydrates. We store carbohydrates in the liver and in the muscles. So on your stored carbohydrates, you can run about 20 miles because you burn, depending on your body size, somewhere in the neighborhood of 100 calories per mile. It's kind of a good ballpark figure, it's 100 calories per mile, walking or running. And so you got, again, enough calories to run, give or take 20 miles on your carbohydrate stores. Your fat stores, using that example that I just gave you, you have enough calories in your average college-age male to run approximately the entire west coast of the United States. So, and that's not somebody who is overly fat. So fat is a really efficient fuel source, which is good because then we can go for long times between meals and long times, So if there's some sort of where for whatever reason you can't eat for several days, those fat stores are really handy. If you are trying to maintain a certain aesthetic and get your body fat really low, it's tough to get rid of those fat stores because, like I said, they're really efficient fuel sources. And another thing about fat is that it is active from an endocrine standpoint. So remember, we talked about endocrine glands last time. Anything endocrine deals with a hormone. So fat has a hormone that it secretes called leptin. And so when fat cells are full, they secrete leptin. And so then leptin interacts with your hypothalamus, which is the part of the brain that deals with your hunger drive. And so then it reduces hunger. So when fat cells are full, they send out this chemical signal, this hormone, leptin, that tells your brain, hey, all of our energy storage sites are full, so we're good, you don't need to eat anymore. And then the downside, of course, is when fat cells aren't full. So for example, when you lose weight, your little fat cells are going to shrink. And so when your fat cells shrink, you're using some of your energy reservoir, and so the fat cells then stop secreting that hormone, stop secreting leptin, and so the brain is no longer getting the signal that, hey, we're full. And there's an antagonistic hormone called ghrelin, which is the hunger hormone. And so essentially, kind of the interesting part about that is sort of your fat cells, in a way, work against you when you lose weight, because they essentially signal to the brain like, hey, we're getting low on energy, you should eat more. And so it increases that hunger drive. And then obviously that makes it harder to lose weight and to maintain that weight loss. So that's your adipose tissue. Other things it does, I mentioned insulation. It also acts as a padding, I mentioned that as well. And then it sort of acts to kind of fill in gaps in certain areas of the body. So for example, your Achilles tendon, you're probably familiar with that. That's the big tendon on the back of your ankle. There's kind of a gap between the Achilles tendon and the nearby bones, so like your talus and your calcaneus, so your heel bone and ankle bone, kind of ways to think about those two. And so there's a fat pad there. There's also a fat pad underneath your patellar tendon, so that's the tendon on the front of your knee, that really obvious one. There's a fat pad behind that as well. So adipose tissue sometimes kind of fills in those gaps. Reticular tissue, we're not really going to talk about, but that's a picture of reticular tissue. So it sort of forms this soft skeleton that blood cells can attach to fairly easily. So we find reticular tissue in bone marrow where we're going to make new blood cells, and we also find it inside of the spleen and helps sort of form that internal skeleton of the spleen. So those are your loose connective tissues proper. Let's talk about dense connective tissues proper. So the first one is dense regular. And so loose versus dense, what does that mean? That refers to the concentration of fibers. So in your loose connective tissue, you don't have a ton of fibers, right? And so I showed you like the areolar tissue where it's mostly ground substance. I showed you the adipose tissue where it's mostly fat, or fat cells. And on the other hand, our dense connective tissue, it's mostly collagen and elastic fibers. So dense tissues then are mostly fibers, very little ground substance, and then relatively few other cells in them. So it's basically almost exclusively collagen. So in those, so we got our dense regular connective tissue, and this is a picture of dense regular connective tissue here. Regular versus irregular, what that deals with is the direction that the collagen fibers run. So in the case of dense regular tissue, all the collagen fibers run one direction. So you can see they all go this way. They are kind of wavy, which will be important here in a second, but they have a little bit of waviness to them. And so examples of dense regular connective tissue are your tendons. So remember, your tendons connect your muscles to your bones. Ligaments, which connect bones to bones. And then fascia, which is a type of connective tissue that wraps around muscles and then connects muscles to bones, like through sheets. So for example, tibialis anterior, one of the muscles on the front of your shin, has this sheet of fascia that connects it, like basically runs the length of your shin to connect it to your shin. So that's fascia. And then dense irregular connective tissues we find in our joint capsules. And so again, the difference there is that the collagen fibers, rather than running in one direction, as they do in dense regular tissue, in dense irregular tissue, the fibers go in every which direction. So the fibers are going this way, they're going this way, they're going this way, over here, all kinds of different directions. And so we find that in joint capsules. And why that matters is the capsules of the joints connect the two bones. So usually ligaments are thick parts of the capsule. I say usually. A lot of the times, ligaments are thick parts of the capsule. Sometimes they can be completely separate from the capsule, but a lot of times they're actually, like I said, thick parts of it. But the capsules themselves, the fibrous layer of the capsules, like I said, the fibers run every different direction. And so why that matters is that helps, in a joint like the shoulder, which can move in all three planes. You can bring your arm out to the side, you can bring it forwards and backwards, and then you can do internal and external rotation. Those fibers running in different directions, each set of them protects a different type of movement. So some fibers will be stretched out when you reach your arm out to the side. A different set of fibers potentially will be stretched out when you internally rotate the arm versus externally rotating the arm. And so those fibers run a bunch of different directions to protect against all the different possible ranges of motion or different movements that we can do with that joint. So that's why they're irregular. That's why they go a bunch of different directions. The elastic fibers, so we're not going to talk about those a ton. You do see those in the ligaments in the spine. Particularly, there's one on the posterior aspect of the vertebral foramen. So there's a hole in the vertebrae that it would be really helpful to have had 201 at this point. But inside of your spine bones, there's a hole in the back. on the posterior aspect, and so that's where your spinal cord sits. And then lining that hole on the most posterior aspect is a ligament called the ligamentum flavum, the yellow ligament. And it's called that because it looks yellow, but the reason it looks yellow is because of the high concentration of elastic fibers in it. So it's a really elastic ligament. It bounces back, not stretchy, but it's really good at bouncing back to its original length. We also see that a lot of elastic fibers around large arteries. So, for example, in the aorta, so when blood leaves the heart, it goes into the aorta and then out to the rest of the body. And so the aorta is under tremendous pressure. The heart can generate quite a bit of pressure whenever it contracts during, maximal exercise. And so the aorta has to be able to stretch and recoil. And so the elastic fibers around that major blood vessel are primarily responsible for doing that. So a lot of your big arteries, even beyond the aorta, have a lot of elastic fibers around them to help return them back to their original shape and propel blood along or through the rest of the arterial system. All right, so in terms of connective tissue characteristics, one of them is elasticity. And so I have on there that elasticity means to return to its original length, but really what elasticity means is to return to its original configuration. So for example, if we take a ligament, which again is going to connect bones to bones, if we stretch that ligament out, that's a tensile stress, we're pulling it apart, and if we remove that tensile stress, then that ligament's going to bounce back to its original length. So that's an example of elasticity. So usually when we think of elasticity, we think of something that's stretchy, but it's not always something that's stretchy. So for example, if we think about adipose tissue or fat, that tissue is pretty good at resisting compression. So if we mash on that tissue and then we remove that compressive stress, then the fat tissue will bounce back to its original configuration as well. So elasticity really means the ability to change shape and return to that tissue's original configuration. So whether we're pulling the tissue apart or compressing it, most of your connective tissues are pretty good at returning back to their original configuration, and that's elasticity. The other one is extensibility, which is the capability of being stretched. So we talk about that primarily in the context of things like joint capsules, ligaments, tendons, those kinds of things. But the extensibility then means that tissue can stretch. So connective tissue then is generally capable of being stretched and then returning back to its original configuration. So a couple other terms that are related that aren't necessarily characteristics of connective tissue. So one of them is a term I just used a couple times, which is a stress. So a stress is a force or a load applied to a tissue. So the example I used was a tensile stress. So if we pull a ligament apart, that's a tensile stress. And by pulling it apart, that's going to cause a change in shape of the tissue. So it's, in the case of that ligament, it's going to lengthen it, right? And so that lengthening, that change in shape of the tissue is strain. And so tissues then respond to stress by undergoing strain, by undergoing a change in shape or by undergoing deformation. And so what I've got here is what's referred to as a stress-strain curve. So stress is on the y-axis, strain is on the x-axis. And so what this means is that as we go up the y-axis, we're increasing the stress. So we'll stick with the example of pulling a ligament apart. As we move up the y-axis, we're pulling apart harder and harder and harder as we get up higher on the y-axis. And then on the x-axis, in response to that, we're going to get the degree of change in tissue length because we're pulling the tissue apart. So it's going to change in length more and more and more, corresponding with the amount of stress that's applied to it. So think back to that picture I showed you of connective tissue. Let's go with here. I'll show you the picture again. This one. All right. So of dense regular connective tissue. So you've got these collagen fibers that are kind of wavy here, right? So that is a tendon that doesn't have any tensile stress on it. It's not being pulled apart. All right, so why that's going to matter here in a second is that when we apply just a little bit of tensile stress, when we pull that tendon apart a little bit, that ligament apart a little bit, when that happens, the first thing in terms of the deformation, the strain in that tissue is that those waves go away. Those collagen fibers go from being wavy to just being one straight line. And so that's this first region here. So you go from being these wavy collagen fibers to being a straight line. And then if we keep putting even more stress on the tissue, if we keep pulling it apart harder and harder and harder, we are then going to actually stretch those collagen fibers up until this point. But the elastic limit, what that means is if we remove that stress, if we stop pulling that ligament apart, it's going to return back to its original length, right? So it's elastic, so it's going to return back to its original length. But if we keep applying even more tensile stress, if we keep pulling apart harder than that, with more force than that, then you're going to actually stretch the tissue out. And so you're actually going to, so once you get past the elastic limit, if we release that tensile stress, if we stop pulling tissue apart, it's not going to return all the way back to its original length. The tissue is now effectively longer. So we've permanently changed the shape of the tissue. And so a plastic change is a permanent change. So now we've structurally lengthened the tissue a little bit. And so where all this matters is in terms of damage to connective tissue. Like when we talk about ligament sprains, there are generally 3 categories of ligament sprains. So the first is grade 1, which is where you just overstretch the tissue. And so that's what we're talking about here. So you've overstretched the tissue, you've made it longer, right? But you haven't really torn any fibers, or if you have, it's very much microscopic damage to the ligament. And then if we keep applying even more stress than that, you're going to get some more macroscopic damage. So you're going to actually have tears of some of the collagen bundles. And so it's effectively then a partial tear. So over here is kind of a grade 2, which is a partial tear of the ligament. And then if we keep applying even more stress, then what we're going to get is a full tear of the ligament, which is both failure and rupture. So then the ligament tears. So grade 1 sprain, which is over here, again, is where we've stretched the ligament out. It's not going to return back to its original length. It's going to stay lengthened out. But you don't have any macroscopic, you don't have any obvious damage to the ligament. And then again over here in grade 2, now you've got more macroscopic damage. Effectively, grade 2 is a partial tear, and then a grade 3 is a full tear. So in terms of how that applies then, we'll stick with that. So with grade, those are your, like I said, those are your grades 1, 2, and 3. Yeah, that's good for now. The other term I want you to know is creep. And so creep deals with a low intensity, long duration stress. So for example, if you, let's go with this. So really common example of knee dysfunction after, let's say, an ACL tear. So your ACL is your anterior cruciate ligament. It is one of the primary stabilizers of the knee. And after people tear it, oftentimes one of the dysfunction issues that they'll have is that they can't fully extend their knee. So that's called an extension lag. And so what happens is that the back part of the capsule scars down, keeps you from fully extending the knee. And so one of the ways that we can fix that then is to try to do a low intensity, long duration stretch of that posterior part of the capsule. So the way that that's typically done is have the person lying face down, like with their knee hanging off a table with like an ankle weight attached to their ankle, maybe 3 pounds. And they'll just lay like that for 10, 20 minutes. And when they do that, that low intensity, long duration stretch will actually cause a realignment of those collagen fibers, and it'll cause them to increase in length. And so when we do that, that allows then hopefully full knee extension to return. All right, so those are our characteristics. Next thing, we've got a case study. So the athlete pictured there is an athlete named Flo Hyman, and she was captain of the U.S. Olympic volleyball team in the mid-1980s. So in a match against Japan in 1986, Flo was pulled out of the game. I think she was feeling okay at the time, but she's pulled out of the game. She goes over and sits on the bench. And while she's sitting on the bench, she collapses, like doesn't say anything to anyone and just collapses on the bench. So medical staff, hustles over and they attend to her. And when they arrive at her side, they find that she has no pulse, and then she stopped breathing shortly thereafter. So basically just collapsed on the bench. When they arrive, she has no pulse, and like I said, shortly thereafter, she's not breathing. Other things to know about Flo that are relevant is that she was very tall. No surprise, right? Olympic volleyball player. She's very tall. So she was 6'5". She has very long arms. And so by saying that, I mean that her wingspan is wider than she is tall. So she's 6'5" tall, and her wingspan was even wider than that. So probably like 6'6", 6'7". So really big wingspan. On top of that, she's very slender, which you can see there. Had very large hands for her size, and she was nearsighted. And it also previously been noted that she had relatively loose joints, so she could, hyperextend her knees, hyperextend her elbows, those kinds of things. So the question is, well, what happened, right? So she, has these things. She's really tall, big wingspan, relatively loose joints, and then just collapses on the bench at the side of a volleyball game, or on the side of a volleyball game. And so what happened there is that, so obviously, if she doesn't have a pulse, there's something cardiovascular going on. And in this particular case, she had an aortic dissection. And so your aorta, as I mentioned, is the first blood vessel leaving the heart. So your left ventricle of the heart pumps into the aorta, and then that distributes blood through the rest of the body. And so basically her aorta ruptured and just started to leak blood, and it would be more violent than a leak. But you get lots of blood then flowing into the thoracic cavity. And so, well, why did that happen? The reason that happened is she had a condition called Marfan syndrome. And so Marfan syndrome is a connective tissue disorder. It's a genetic disorder. And so specifically what happens there is that you have a defect in the ability to make a protein, a connective tissue protein called fibrillin-1. The name doesn't matter, or the specific protein doesn't matter. But what does matter is somebody who has Marfan syndrome, their collagen fibers are a little bit more brittle. It's kind of a way to think of them, right? It's easier to break them. And so the way that manifests physically in terms of obvious signs of that is that, like I said, they tend to be fairly loose jointed. So because the collagen in the joint capsules has a little bit more give to it than it otherwise would in somebody who didn't have that syndrome, then they are what is commonly referred to as double jointed. So they can hyperextend their knees, they can hyperextend their elbows. One of the other tests in terms of physical tests for that is if you can take your thumb and touch it to the anterior aspect of your forearm relatively easily. Now most of us can do it if you really just hammer on it, but people who have loose joints are able to do that relatively easily. So basically what happened was, again, she has relatively brittle collagen fibers, and so as a result of really strenuous athletic participation, basically there was enough damage done to the aorta that the connective tissue and those elastic fibers couldn't sustain their structure, and so that pressure overwhelmed them, and then you get a rupture of that vessel, which in this case is the aorta, and then so she died of internal hemorrhaging is what actually happened there. So there have been a couple cases of this recently where athletes have been disqualified from participation. One of the ones that's probably the most, famous, if you will, is a basketball player named Isaiah Austin, who played for Baylor University. In 2014, he was drafted into the NBA, and as part of the physical, they discovered that he had Marfan syndrome, and so he was not allowed to play. Because the idea here is that you want to avoid really intense, vigorous athletic participation, so really heavy weightlifting and sprinting and big explosive jumps, those kinds of things that are obviously a significant part of the game, whether it's volleyball or basketball, and then obviously the weight training that goes along with them. You want to avoid those really high intensity activities because those are going to produce big spikes in blood pressure. And so if you've got an aorta that doesn't have as strong of connective tissue around it that we would like, then we want to avoid those big spikes in blood pressure. So typically people who have Marfan syndrome have to discontinue vigorous athletics, so high intensity athletics. So some of those other physical features are common. So people who have Marfan syndrome tend to be really tall. They tend to have that really big wingspan. Like I said, tend to be double jointed. Nearsightedness falls in there as well. So one of the interesting things, or I guess one of the hard parts about that is, that description in terms of being tall with a really big wingspan and really big hands fits a lot of really high-level athletes, and almost none of them have Marfan syndrome. But, there was a study a few years ago, and at this point it's probably 10 years ago, but they looked at the wingspan of NBA players. and only one person in the NBA at the time didn't have a wider wingspan than they were tall, right? So that's a very common characteristic of NBA players. And again, none of them have Marfan syndrome. So it is, just because somebody is really tall and skinny and then has a big wingspan doesn't mean they have Marfan's, but if somebody does, then potentially that is a condition that would force them to discontinue athletic participation. All right, so another sort of a case study in connective tissue. So one of the things I talk about a lot is obviously the utility of keeping moving. So, ideally avoid getting old, or since you can't, and none of us can, at the very least, try not to stop moving. So I'm going to show you, so that's David Beckham grabbing his ankle. So I'm going to show you a picture of an injury that he suffered in 2010, or actually a video, sorry, of an injury that he suffered in 2010. And so watch his left ankle here. Okay, it's pretty subtle. It's not like super obvious. There's not a bone poking out or anything. But what you're going to see is as his foot moves into dorsiflexion, so as his toes come up toward his head, you're going to see that his ankle just kind of gives out. And so usually in somebody who's suffered an injury like that, which I'll tell you what it is because you can see at the top of the screen, usually in somebody who suffered an injury like that, they complain of hearing and feeling a pop, sudden sharp pain, and oftentimes they think somebody kicked him. And you can kind of see he looked around to see if there was anybody near him. And so, yeah, he tore his Achilles tendon. Your Achilles connects your two big calf muscles, technically three, but your two big calf muscles to your heel bone. And so when that ruptures, usually that pulls away from the heel bone. Usually it ruptures at its connection there. And I'll show you one more here that's a little bit more obvious and newer. So this is Greg Jennings, who at the time was, or sorry, Brandon Jennings, who at the time was 26 years old. Whoops, guess we got sound. There we go, didn't want sound there. All right, so you're gonna watch Jennings for the Pistons. Whoops, sorry, back up a little bit more, go to 104. So watch as he steps back there with his left leg, okay? So same kind of position that Beckham was in, and you're gonna see similarly that his ankle kind of gives out, right there. And so that is an overstretch and tear of the Achilles tendon. So Achilles tendon injuries are very common in men between the age of 30 and 40, and it goes up a little bit more than that between the age of 40 and 50. And so, like I said, Jennings was 26 at the time. Whenever David Beckham tore his, he was 38 years old. So why is it that guys in their 30s, and I say guys, it is much more common in men than it is in women, why is it that guys in their 30s and 40s are much more likely to suffer Achilles tears than younger athletes? Well, one part of that is because of the changes in the tendon as we age. So remember that your dense regular connective tissue has lots of fiber, so lots of collagen. It has relatively few fibroblasts, relatively few of those cells that can divide and mature into fibrocytes. And the number of fibroblasts decreases across the lifespan. So as you get older, you have less of those cells that can make copies of themselves and that can make more collagen. So you can't repair the tendons as well as you age. So that's one problem. And then another problem is that the tendons are not very vascular to begin with. They have a little bit of a blood supply, but not much. And that blood supply decreases across the lifespan too. So some of those capillaries go away. So not only do you lose the cells, the fibroblasts, that can divide and make a bunch more collagen, so you can't repair the tendons as well, but then you don't have as good a blood supply, so you can't get the things that you need to the cells that would do the repair work. And so the result of it is, as you age, your tendons change and they become stiffer. So they're not as extensible. You can't stretch them out quite as much, but then they become effectively a little bit more brittle. They're easier to rupture. And so the reason that men in their 30s are most common or most likely to get an Achilles tendon injury is because their tendons have changed because they're starting to move into that midlife age range, but they're still trying to do the activities that they used to do. So one of the common things, so obviously you see it in pro athletes as well, but one of the really common scenarios with Achilles strains are that you get them in weekend warriors. So people who haven't really done much throughout the week, but then they decide they're going to go play pickup soccer or pickup basketball on the weekend. They land wrong and they tear their Achilles. So they're trying to do the things that they had been doing, when they're in their late teens, early 20s, and they were actually probably doing some level of conditioning for that sport. Now they're just going to go out and play. They don't realize their tendons have changed, can't repair themselves as well, don't have as good a blood circulation. There's more cross-linking between the collagen fibers, so they're more connected to each other. And so all of those things add up then to a tendon that's not as able to repair itself and is a little bit more brittle and more likely to rupture. And so having said that, the tendons don't typically rupture mid-substance, so you're not going to get a tear like right in the middle of the Achilles. You're actually going to get where either the Achilles is going to pull away from the bone, specifically the calcaneus, which is your heel bone, or it'll pull away from your calf musculature is kind of the other thing that it can do. So I'm going to show you a picture that's a little gross. You already kind of saw it a second ago. And so this is what an Achilles rupture looks like. And so if this person had their Achilles intact, this would be a nice straight line here. But since the Achilles has pulled off of the calcaneus, the calf musculature has kind of rolled up on itself a little bit and taken the tendon with it, and so then you get this little gap here. The test for an Achilles rupture is to grab their calf and squeeze, and so if somebody's Achilles is intact, when you squeeze their calf, their foot will move. If they've torn their Achilles, their foot won't move. So in terms of don't get old or don't stop moving, one of the things is that continued activity, so rather than just being a weekend warrior, but like continuing consistent activity helps to maintain fibroblasts for longer, so to maintain the ability of the tendon to repair itself for longer. It also maintains those capillaries to the tendon for longer. So basically your tendons age more slowly as long as you maintain activity. So you're less likely to suffer an Achilles tear if you continue to be active. Now, based on Brandon Jennings doing it at 26, sometimes it just happens, right? You just overload the tendon. But you're less likely for it to happen if you continue to keep moving. We also see a similar thing in the heart. So the collagen in the heart also changes with age. So it changes specifically from a type 3 fiber, which is so type 3 collagen, which is present in the hearts of younger people in greater quantities. So type 3 collagen is more extensible and more elastic. It's able to stretch and then recoil pretty effectively. And as we age, the fiber or the collagen type shifts from type 3 fibers or type 3 collagen to type 1 collagen. So type 1 collagen is really strong, again, steel cables, but it can't stretch as much and it also can't recoil as effectively. And so the result of that is that the heart is less able across the lifespan to eject as much blood with each beat. And so if the heart can't stretch out and then eject as much blood, it compensates by contracting harder. And so that's one of the reasons that we see an increase in blood pressure across the lifespan is actually related to collagen changes in the heart. And so as it relates to this discussion, if you stay active, if you continue to exercise, particularly if you continue to engage in vigorous exercise, so with higher heart rates, you can kind of put off that shift in collagen type. You can maintain your cardiac output into older age. So there was a study from I think 2016 where they looked at elite distance runners and they followed them starting in 1968 all the way until 2013. And they found, and so when I say elite runners, these are like Olympic level runners, but they found that in 2013, when these athletes were in their late 60s, they had the same aerobic capacity as the average college age male, right? So even though they were almost 70 years old, they could still turn over the same amount of oxygen as a college age male. And a big part of that is that their heart is going to function similarly. So basically, again, they kind of put off those age-related changes in the heart. So don't stop moving. Keep your tendons young. Keep your ligaments young. Keep your heart young by continuing to engage in exercise. And again, if you do stop moving and then suddenly start doing something really intense like pick up basketball, it's a good way to hurt yourself. All right. So let's talk about cartilage now. So 3 types of cartilage here. Elastic, I don't care that you know as much, but these 2 I do want you to know, hyaline and fibrocartilage. So hyaline cartilage, things that I want you to know about it. one, it's the most abundant in the body. It's kind of all over the place, right? So hyaline cartilage includes these costal cartilages that connect your ribs to your sternum. But in addition to that, hyaline cartilage, and why I generally care about it, is that it's the kind of cartilage that lines the ends of your long bones. So it's the kind of cartilage inside of joints, so lining the end of your humerus and your glenoid cavity, for example. And so the articular type of hyaline cartilage serves a few purposes. One, since it lines the ends of those long bones, it serves a purpose of shock absorption, so it's able to withstand compressive stresses really well. And then two, it's really slick, so it helps those two bone ends slide on each other without dragging. So cartilage, or specifically hyaline cartilage, so you can see it's avascular, so it doesn't have a blood supply. It actually has an outer layer of tissue called the perichondrium, which is also another type of connective tissue. So that perichondrium supplies blood to the most superficial aspect of the cartilage. And as mentioned there, it has lots of GAGs, the glycosaminoglycans. And so because of that, so you can see these little chondrocytes here, lots of extracellular matrix here in our hyaline cartilage. And so most of this is water. So there's lots and lots of GAGs, which, as I mentioned, the more of those you have, the more like syrupy that extracellular fluid is. So this extracellular fluid is going to be pretty syrupy, pretty viscous, pretty thick, right? And so the reason that matters is that helps with those compressive stresses. So whenever you smash this tissue, it's going to kind of squish some of that fluid out, and then you've got that perichondrium surrounding that cartilage, and then that'll rebound, and then it'll push that water back into the middle of the cartilage, and so then it resumes its shape. That's that elasticity that we talked about. So those, as mentioned earlier, the immature cartilage cells are called chondroblasts. Chondroblasts, again, the blasts secrete the extracellular matrix, so they lay down all of this collagen out here. And then as we reach about the age of skeletal maturity, most of those blasts, if not all of those blasts, have changed to being chondrocytes. And so chondrocytes are really good at maintaining this matrix. So if some of these collagen fibers that we can't really see, but these are a bunch of collagen fibers here, if some of these fibers tear, the chondrocytes are good at kind of doing some spot repairs here and there, but they're not good at repairing lots and lots of damage. And so as we move through the lifespan, then the cartilage is less able to repair itself. And so in the case of hyaline cartilage, since that lines the ends of long bones, you'll get a little bit of microscopic damage, and then you get that over and over and over again, and then that results in the cartilage wearing down and exposing the underlying bone. And so in that instance, that's where you've got osteoarthritis, or more colloquially known as just arthritis, is the result of the wearing down of that hyaline cartilage, or that articular cartilage that lines the ends of the long bones. So for now, big things to know about hyaline cartilage: lines the ends of long bones. It's really slick, helps the bones slide on each other, and then it also helps dissipate some of those compressive forces. Elastic cartilage, like I said, I don't really care too much about it because it forms your ears, it forms your epiglottis in your throat, and we'll talk about the epiglottis later. So elastic cartilage, not super important for now. Fibrocartilage, though, so fibrocartilage has these rows of chondrocytes and then rows of really thick collagen fibers between them. So lots of collagen fibers. So as opposed to the hyaline cartilage, which had lots of water in it, fibrocartilage has relatively less water and lots more collagen fibers. So it's a denser kind of cartilage. And so the job of fibrocartilage is primarily shock absorption. And so, for example, you see fibrocartilage in the intervertebral discs. So obviously this is your spine. These are your vertebrae or spine bones, and then you've got discs between them. And so the outer portion, or the most superficial portions of the discs, are fibrocartilage. We also see fibrocartilage in the menisci of the knee. And so remember, those are these chunks of cartilage, fibrocartilage, that sit on the medial and lateral tibial plateaus. We see fibrocartilage in the sternoclavicular joint as a shock absorber as well. Fibrocartilage forms the labrum in both the hip and the shoulder, so the acetabular-femoral and glenohumeral joints. So fibrocartilage, again, primary job is shock absorption. All right, so one more case study I think that's the last thing I have for you today. Sorry for it's the last thing for today. Sorry so long. So we're going to pretend that you are an athletic trainer, and a high school football wide receiver reports to the training room, and he is complaining of diffuse knee pain, like his whole knee just hurts. He says it's been bothering him for a few weeks. He doesn't necessarily remember a specific incident, like he can't say, I did this thing and then my knee hurt. It was just like, it's been hurting for a few weeks. He says it may be related to, at one point he was running a route, an out route where he stopped to change direction and then cut laterally. And when he did that, it felt like his knee just gave out, and he felt like he's had some problems since then. And in looking at his knee, you notice that it's swollen. So we're going to pretend it's his left knee in this case. So on his right side, you can see the outline of the patella pretty well. On the left side, things get a little hazy. And so on the left side here, he's got effusion, he's got swelling inside of the knee. So he has this intermittent type swelling. And then in addition to that, he complains that the knee either gets stuck, like it'll get stuck in a certain position, or sometimes it feels like it just gives out when he's walking or running. So, and then the other thing he's got is what's referred to as joint line tenderness. So at the interaction of the tibia, the shin bone, and the femur, he's going to have some pain, specifically on the medial side, so over here, but obviously on this knee. So what's he got going on? That's a classic medial meniscus tear. So what you're looking at here is the right knee from the front. You got your femur, which is your thigh bone here, your tibia, which is your shin bone here, and then your cruciate ligaments, your ACL and your PCL. And so you've got two sort of semicircles, if you will, of fibrocartilage. So you got the medial meniscus here, which is fibrocartilage, and the lateral meniscus here, which is also fibrocartilage. And so what he's done is, as a result of that sudden stop and change of direction, he's torn the medial meniscus. And so what's happening there that's causing that feeling like the knee just gives out is that torn portion of the cartilage is actually moving inside of the knee joint and kind of getting in the way of the interaction of the femur and the tibia. And so that produces that giving out or getting stuck sensation. Anytime you've got damage inside of a joint, whether it's a tear of the meniscus or osteoarthritis or an ACL tear, when there's damage inside of a joint, it's going to start the inflammatory process in the joint, which then causes swelling. So swelling is kind of a byproduct of the inflammatory process. And so he's got that intermittent swelling as a result of damage inside of the joint. Make sure I don't want to mention anything else. Nope, that's good. All right, so like I said, classic presentation of a meniscus tear, which is damage to the fibrocartilage. All right, so like I said, that was a long one. Sorry this one was so long. But the next one will be fairly short. Mostly I want to talk about the inflammatory process and the tissue repair process on the next one. And like I said, I promise the skin one will be a short talk. So that's it for now. We'll see you next time to finish up Chapter 4.